Hey guys, today we're going to talk about obesity and some anesthetic implications. And sorry about my voice, I'm battling a cold. So I've broken down this talk into 7 sections, and you can see the objectives, some epidemiology, definition, pathophysiology, pharmacology, and some operative considerations. Now, according to WHO, obesity is a condition with excess body fat that negatively impacts health and well-being. That's just a general definition. It's, as you know, reaching an epidemic proportion worldwide, not just in the US. And for the first time in our history, there are more obese patients than there are underweight individuals. About one-third of people in the US are obese, and as you can imagine, there's an uneven distribution geographically, racially, and socioeconomically. And the overall trend is increasing. And the prevalence of obesity is predicted to reach about 50% by 2030. The most common causes of death in obese patients are coronary artery disease, diabetes, and cancers. Surgery in this patient population is considered high risk, but careful planning, pre-op risk assessment, proper anesthetic management, strict thrombotic prevention, and effective post-op pain control will all help to reduce the risk. With appropriate perioperative management, obese surgical patients can achieve safe and effective surgical outcomes, just like any other patient population. The definition of obesity includes the presence of excessive body weight for the patient's age, gender, and height, and is often based on the following concept. Ideal body weight is a concept originated by life insurance companies, and they reference height weight tables. It's the weight associated with the lowest mortality rate for a given height and gender and can be estimated using the Broca's index. So ideal body weight is calculated as height minus x, where x is 100 for adult males and 105 for females. Predicted body weight is a concept similar to ideal body weight and is more commonly used in the medical literature. Predicted body weight is usually calculated in males as 50 plus 0.9 times height in centimeter minus 152.4, and you can see the calculation for females. Lean body weight is the total body weight minus the adipose tissue. It's the combination of body, cell mass, extracellular water, and non-fat connective tissue. It approximates about 80 to 75% of total body weight for males and females. And even though it's more accurate formulas have been proposed, in morbidly obese patients, increasing the ideal body weight by 20 to 30% gives an estimate of lean body weight. In non-obese and non-muscular individuals, total body weight is pretty much approximates ideal body weight. And these are important because we use different kind of calculations in terms of weight-based dosing for different medications. In clinical practice, it's common to utilize the body mass index BMI to estimate the degree of obesity. The BMI is determined using patients' weight in kilograms divided by height squared. And if BMI is more than 30, you're obese. Morbid obesity is defined as BMI of 40 or higher, and super obese more than 50. And if BMI is more than 60, it's super obese. There's some weirder and more interesting names, but I think this is as far as I'd like to go. BMI differentiates obese from non-obese adults, and it estimates body fat because it adjusts for height, while it also correlates with body weight. But it can't distinguish between overweight and overfat, as people with lots of muscle, bodybuilders, can easily be classified as overweight or obese if you just use BMI. So other factors like age, fat content, and distribution, like waist circumference and waist to hip ratio, we should think about those, and as well as other health risk predictors that use the concept of BMI. The anatomic distribution of body fat has associated pathophysiologic implications too. In android obesity, or the central obesity. Adipose tissue is pretty much located in the upper body, and it's in truncal distribution. It's associated with increased oxygen consumption and increased incidence of cardiovascular disease. Visceral fat is particularly associated with cardiovascular disease and left ventricular dysfunction. In gynecoid obesity or peripheral obesity, adipose tissue is located pretty much predominantly in the hips, buttock, and thighs. This fat is less metabolically active, so it's less closely associated with cardiovascular disease. Body circumference indices like waist circumference, waist to height ratio, and waist to hip ratio help to classify these patterns of obesity and correlate with mortality and the risk for developing obesity related diseases. Waist circumference correlates with abdominal fat and is an independent risk predictor for disease.